Okay, can I start? Okay, okay, I will start. So I'm going to talk about the international collaboration of CAR T cell therapy using non-viral vector system. I'm showing the two patients. Both patients received our piggyback transposon CD19 targeted CAR T cells. One left side 9-year-old girl received in Japan, and also the right side, the lady in Thailand received our piggyback transposon CAR T cells, and both are now pretty much fine. I'm gonna show the detail later. So this is my COI slide. So acute lymphoblastic leukemia is the most common malignancy in children. And ALL is 25% in all childhood cancer, and also the 70 to 80% of all childhood leukemia. So that's why for pediatrician, ALL is one of the most important cancer. So as you may know, that CD19 targeted CAR T cell therapy has been successful. So nearly 10 years ago, several papers published to show the CD19 targeted CAR T cells effective in the relapsed refractory patients of acute lymphoblastic leukemia or non-Hodgkin lymphoma. So as you see, response rate was 70 to 19%, very high, although the enrolled patients are all relapsed after the transplantation or chemorefractory patients. And so this girl in photo was the most famous patient who received the CD19 CAR T cells in Philadelphia Children's Hospital, Emory. So this photo was described in New York Times in 2012. And 1 year ago of this photo, this patient had a chemotherapy resistant acute lymphoblastic leukemia. But 1 year later, so she is pretty much fine. And she is updating every year his beautiful photo, already more than 10 years survival now. So it's already CAR T cell design has been repeatedly explained, so I can skip this. But basically, we use a monoclonal antibody, and we need to transduce the antibody to the patient lymphocyte, then culture 7 to 14 days, then return the cell to the patient. So the firstly, the 2017, the first CAR T cell product was approved. That's a Tisa-cel, and the FDA approved with price $500,000. So that means nearly $500,000. And also in England, $400,000. And in 2019, Japan also Tisa-cel was also approved with $300,000. Still very high cost, high price. So this high cost of the CAR T cell product has a problem. So many international meetings suggesting this CAR T cells has a financial toxicity or financial burden. for the patient. And there are concerns for the financial toxicity may limit access to this therapy. In fact, although the US and some countries in Europe and Japan approved this CD19 CAR T cells product, many Asian countries, except for Japan, and recently except for Korea, vast majority of Asian countries could not approve this high cost of the high price of the CD19 CAR T cells. So that's a problem. So to solve these problems, we are now trying to develop the relatively cheaper CAR T cells, less expensive CAR T cells. So this slide shows the approaches to the genetically engineered lymphocytes. So CAR T cell product that has been approved are using a viral vector system, either retroviral vector or lentiviral vector. But using viral vector means relatively high cost. But so we are now using a transposon system as a non-viral vector system. So transposon vector system has mainly two. One is a Sleeping Beauty and another is a piggyback. So we are using piggyback transposon. So this slide shows a piggyback mediated gene transfer system. So as yesterday already Dr. Yagyu presented the non-viral vector system session, and also today Dr. Saito in Shinshu University also mentioned about the piggyback transposon system. And piggyback transposon system has two vectors. One is a transposon vector, and another is a transposer vector. So co-culture of these vectors with patient lymphocytes, and also electroporation make the CAR genes make integration to the genome of lymphocytes. Advantage of the transposon system is a very quickly transduction, and also most importantly, less expensive. So there is no need special facility, and also biologically safety testing is relatively mild as compared with the viral vector system. So Professor Nakazawa in Shinshu University now firstly reported the piggyback transposon system can be used to make CAR T cells. And also he shows a stable and long-term expression of the genome in the product. However, the weak point of the piggyback transposon system was relatively low transduction efficacy. In fact, the original method of piggyback transposon shows only 5 to 10% transduction efficacy. That's why we collaborate with Dr. Nakazawa in Shinshu University to improve this transduction efficacy. So gradually we could improve the transduction efficacy as you see. And finally, we achieved the transduction efficacy of about 50% on average in healthy donors. So this is comparable to the viral vector system. So we submitted a patent of several patents related to this technology. And 2 years ago, this patent was approved in Japan, and last year approved in China, and this year this patent was approved in Europe. And now trying to make a paperwork with FDA in the US. So we have a good feeling about the patent approval right now. And after the submitting patent, we published the new improved technology using the viral peptide pulsed irradiated autologous APCs and also several combinations of cytokine. We could achieve the much better transduction efficacy. So using this technology, we could expand the CAR T cells in 2 weeks and achieve the median 50% transduction efficacy. So as you see, so some patients showed us around 70% CAR positive product. And in order to develop the CAR T product, the design of the CAR construct is very important. So it's already known that different CAR design show the different clinical efficacy. So for instance, both CD19 targeted CAR T cells has been approved. Both, one is a CD28 cosmetic molecule domain, axicell, and another is 4-1BB cosmetic molecule type, T-cell. However, for malignant lymphoma treatment, it's known that axicell, CD28 type, has been better progression-free survival and overall survival than 4-1BB cosmetic molecule type T-cell. And also, especially the older age, over 70 years, and if the tumor was bulky, tumor is bulky, over 5 centimeters, so axicell is much better than 4-1BB T-cell cells. So that's the reason why we actually the developing CD28 cosmetic molecule design, and our developing CAR product is exact same design of axicell, except for the transduction method. We are using piggyback transposon method. Axicell can be was made by retroviral vector system. And already yesterday, also Dr. Yagyu presented the unique phenotype of the piggyback transposon mediated CAR T cells, as he showed yesterday. So this is the same slide, I think. The phenotype of the piggyback transposon-mediated CAR T cells show the relatively higher in CD8 as compared to CD4. Mostly the 2 to 3 times higher in CD8 as compared to CD4 in left side. And most importantly, the vast majority of the CAR product showed us both CCR7 and the CD45RA double positive. This major subset means either naive phenotype or T-cell stem cell phenotype. And recently, even in viral vector system, so this slide shows reported from blood advances in 2020. So in axicell for the malignant lymphoma treatment, so durable response after CAR T-cell therapy are related to the number of CD8 T-cells infused in the patient. Also, both CCR7 and CD45RA double positive population, the number of these double positive T cells infused are related to the durable response. I mean, the higher, if the patient receives a higher number of the CCR7 CD45RA, the patient shows a durable more, significantly more durable response. So although we are still treating a few patients, both in acute lymphoblastic leukemia and malignant lymphoma patients, but according to the phenotype of our product, we are expecting that our piggyback mediated CD19 CAR T cells may show the higher efficacy. That's my hope. So this slide shows the in vitro study. If we co-culture of the CD19 piggyback CAR T cells with CD19 positive cell lines, all cell lines are gone in 5 days. And also this slide shows an in vivo study, and immunodeficient mice, when we treat the mice, the mice are surviving. And since this piggyback transposon system is relatively new gene transduction system, we checked the transduction site using next generation sequencing technology among piggyback, retrovirus vector, and lentivirus vector. Using same CD19 genes, we compare the transduction site. So as you see, piggyback transposon has not been different between the retrovirus vector or lentivirus vector regarding the within proto-oncogene or the TSS site, and also gene safer harbor relating. So it means that our results showing that there is no such a safety problem regarding the transduction sites. So this slide shows the clinical grade CD19 CAR T cell using piggyback transposon in Nagoya University, taking a lymphocyte from the patient and transduction with piggyback transposon. Then we culture 10 to 14 days. And this system had used no virus system or no tumor cell lines in the culture, very clean. And this slide shows a self-processing room in the Nagoya University Hospital. So we don't need to make a completely new facility for the viral vector system. As long as a clean bench, clean rooms, we can make a CAR T cells. So in most academia hospital has this kind of self-processing room nowadays. So now we are conducting phase 1 clinical study of piggyback transposon mediated CAR T cells for CD19 positive acute lymphoblastic leukemia. We already treated 9 patients, and now we are moved to the last cohort. Today I'm showing the first 6 patients. So this slide shows patient characteristics. So as you see, most of the patients received already the stem cell transplantation. Two of them are already transplanted twice. And so that means they are very heavily treated before the CAR T-cell treatment. This slide shows the adverse events of the first 6 patients. And regarding non-hematological toxicity, only 1 patient showed a grade 3, that's liver dysfunction. However, without any treatment, this liver dysfunction was solved, improved. Then we moved to the cohort 3, and just last month we finished the cohort 3. Now we move to the 4th cohort. So this slide shows the clinical outcome of the first 6 patients. And unfortunately, 2 patients relapsed. 28 days after the CAR T infusions, all of the patients maintained a complete response or achieved complete response. But 1 patient showed minimal residual disease. Then this patient relapsed soon and unfortunately died. And another patient relapsed 10 months after the CAR T-cell infusion. So except for 2 patients, all of among 9 patients who already treated, 7 patients still disease-free. And the longest patient, 3.5 years now. And so all patients who received our CAR T cells, we could detect the CAR positive T cells expanded in patient body, peripheral blood. And this slide shows the first patient, who relapsed after the stem cell transplantation. Then he received our CAR T cells and showed very mild cytokine release syndrome, low-grade fever, grade 1, and also showed B-cell aplasia. And on day 10, we could detect nearly 4% of T lymphocytes showed CAR positive. So on day 13, after CAR T-cell infusion, he developed some mild headache. So that's the reason why we checked the cell count in spinal fluid. It was elevated to the 78. And we suspected CNS relapse, but it wasn't. We could detect 80% of the cells in spinal fluid was CAR positive. So this patient was pretty much first patient who are treated our piggyback transposon system. Now, so this is right photo was 5 hours after the infusion of CAR T cells. So this patient received high-dose chemotherapy followed by allogeneic transplantation half a year ago, then relapsed. So as compared with bone marrow transplantation, his condition is much better. So that's the patient and his mother was so surprised because very mild chemotherapy, and actually that he could keep the hairs, and even 5 hours after the CAR T cell therapy, he could eat lots of food as usual. That's amazing. This is the beauty of the CAR T cell therapy as compared with bone marrow transplantation. So now he is now 3.5 years disease-free. So another patient, 9-year-old girl, who already received 2 stem cell transplantation, both high-dose chemotherapy or high dose of TBI, irradiation. However, she relapsed. And she received our CAR T cells, and she developed the grade 2 cytokine release syndrome and showed hypoxia. She received tocilizumab, IL-6 antibody. Then cytokine release syndrome was solved. So on day 14, we could detect 30% of her T cell in peripheral blood showed CAR positive. We also checked the spinal fluid again, and cell count was elevated to the 195, and interestingly, 54% of the cells in spinal fluid showed the CAR positive. So this 9-year-old girl already received high-dose chemotherapy followed by allogeneic transplantation twice. The second transplantation was HLA haploidentical transplantation with TBI, 12 grade. Very heavily treated patients. However, now she is now 1.5 years disease-free. This is really beautiful. And we could detect 2 patients who developed the low-grade fever. We could detect the IL-6 cytokines elevated in both patients. And finally, we could find a partner company to develop piggyback CD19 CAR T cells. It's Japan Tissue Engineering company, JTEC. It is located in Aichi Prefecture. It's same prefecture of Nagoya University, very close. And this slide shows the JTEC company. And it's only 1 hour difference between the, by train, 1 hour difference between the JTEC and the Nagoya University Hospital. It's very convenient for us to discuss about the developing of the CAR T product. And also the Chulalongkorn University offered us to conduct a clinical trial using our piggyback transposon system in Thailand. This is 2018. So I was invited to Cancer Immunotherapy Research Forum, like today's forum. So we focused on the CAR T cell therapy at this point, and not only the me, but also the Dr. Nakazawa and also Dr. Yagyu was both invited at the same time. So Professor Natia invited us. And Dr. Yagyu, Dr. Nakazawa, and I met the Dean, Faculty of Medicine in Chulalongkorn University, and he asked us to perform the clinical trial in Chulalongkorn University Hospital. Then we visited King Chulalongkorn University Hospital, the very clean, and they had 20 clean rooms for the transplantations. And also I was surprised that Chulalongkorn University Hospital had 7 cell processing rooms in their university. Although the Nagoya University has only 3 cell processing rooms, actually more processing rooms Chulalongkorn University had. So Professor Nadia visited Nagoya University in 2018, end of the 2018, and we made a contract, the material transfer agreement. Then we started the collaboration to perform the clinical trial in Thailand. So this was actually reported by newspaper in Japan. And 2 technicians from Thailand came to our Nagoya University Hospital, and they could be trained to make a piggyback transposon CAR T cells by themselves. Then finally, IRB in Chulalongkorn University approved to start a clinical trial of piggyback transposon CD19 CAR T cells for both malignant lymphoma and acute lymphoblastic leukemia in 2020. And I received a photo of the party when they treated the first malignant non-Hodgkin lymphoma patients. So this is Japanese restaurant in Thailand, and they celebrated the first patient treatment. And finally, although we had a COVID-19 problem, we could not enroll the 1.5 years due to the ICU occupied. We restarted the CAR-T enrollment, and finally, five patients of malignant lymphoma in Chulalongkorn University Hospital has been treated. And I heard that all of the 5 patients showed a clinical response. And especially one of the patients was fourth relapse of the malignant lymphoma. And as you see, the over 15 centimeter very bulky mass she had, and also multiple metastasis. And after they received the piggyback transposon, 1 month later, all of the disease site achieved the CR, a metabolic CR. And 1 year later, still the patient showed the metabolic response, complete response. That's the reason why the Chulalongkorn University and the Nagoya University together to make a press conference March this year. So I met this lady in Bangkok in Chulalongkorn University. So she became a completely normal life. And blue shirts guy is her husband. So both are very happy. I was so moved to this result. And the press conference in Bangkok, Thailand, and both Nagoya, Dean of Nagoya University and Chulalongkorn University make a comment in the press conference. And right now, in Japan, Dr. Yagyu and Dr. Nakazawa are developing several different CAR-T products. Also, Nagoya University also developing the targeting the different disease using different CAR-T products. So in conclusion, the piggyback transposon method, a non-viral vector system, could be a platform for less expensive CAR-T cell therapy, lowering the cost of CAR-T cell production, especially in Asian countries, is important to reduce financial toxicity of CAR-T cells. So I would like to thank all my colleagues in Nagoya University Hospital, and also not only the pediatric department. I also would like to thank Dr. Seitaro Terakura in Department of Hematology, and especially the Dr. Nakazawa, Shinsu University, and National Cancer Center Hospital East, Dr. Minami, and Hokkaido University, Dr. Goto, Dr. Teshima, and the Kyoto University Hospital, Dr. Arai, and the Kyushu University Hospital, Dr. Kato are now collaborating to start. We are about to start clinical trial for approval of this product in Japan. I appreciate the Dr. Luni in Beirut College University Medicine, and also Professor Dotti in University of North Carolina, and most importantly, Dr. Kuramit, Dr. Spranica, and Dr. Udomosak, and Professor Natia in Chulalongkorn University. Thank you very much.